Okay, can everyone hear me? All right, we'll get started. So my name is Chad Lane, and I have the privilege to get to serve the residency program for the next year as Chief of Medical Education. And one of the wonderful opportunities I'll have in that role is to invite brilliant, fascinating, thought-provoking speakers to come and share their knowledge with us. So that will be part of what we are doing today. And I am excited to welcome everyone to the first installment of this summer's Resident Grand Rounds series. Before I introduce today's speaker, I'd like to make just a few brief announcements. As a quick reminder for the residents, there will be a lunch with our speaker immediately following Grand Rounds, and that'll take place over at 300 George Street right after. For next week, July 7th, we'll be welcoming Dr. Christine Montross, who will be facilitating a writer's workshop with residents following her talk, so keep an eye out for an email to come with further details about that. On July 14th, Dr. George Macari, director of the DeWitt Wallace Institute for the History of Psychiatry, will explore our understanding of the mind through the lens of history, which we're excited about. And on July 21st, our wonderful PRA co-presidents, Myra Mathis and Joe Taylor, will be organizing a special event for our trainees, so that's top secret, so stay tuned. And now it's a privilege to introduce to you our speaker today, Dr. Alice Flaherty. Many of us in this room may remember the first time we became mystified by the brain, how a collection of cells, synapses, and the seemingly infinite happenings among them give rise to joy, to fear, to language, to the human condition. Dr. Flaherty has spent a considerable portion of her career in the pursuit of unraveling this mystery, a pursuit that has captured us all. Dr. Flaherty is a joint associate professor of neurology and psychiatry at Harvard Medical School and a practicing physician at MGH. She completed her bachelor's, her MD, her internship, residency, and fellowship at Harvard. She obtained her PhD from MIT, where she used electrophysiology to study ways in which the brain, specifically the basal ganglia, represents the body. As the director of the Movement Disorders Fellowship and co-director of its Deep Brain Stimulator Unit, her work has focused on brain systems that control human drives, whether to walk, to communicate, and even to create. She has studied how creativity is influenced by interventions ranging from drugs to deep brain stimulation to phototherapy. Her most recent work on idea generation looks at the positive and negative effects of autonomic homeostasis on creativity. In addition to her many scientific papers, she is author of the MGH Handbook of Neurology, The Midnight Disease, a book looking at the brain's role in writer's block and creativity, and The Luck of the Loch Ness Monster, a children's book about picky eating. Each of her books has received national awards and has been translated into multiple languages. Her current project studies the ways in which the brain function and environment interact to create illness behaviors such as hysteria, stoicism, empathy, and dispassion. For this work, she has been awarded 2 fellowships from the Radcliffe Institute for Advanced Study. This is all but a snapshot of her remarkable career, a career sure to continue shedding light on the human mind. And with that, please join me in welcoming Dr. Alice Flaherty.
Hi, thanks. I always love coming to Yale. I have a great time here. The first time I gave a talk, it was in a series that was founded by Helen Gurley Brown, which was such a thrill to be following the footsteps of the Cosmo founder. But today I'm going to talk about something different. As I think some of you are wondering why a neurologist would be here talking about illness behavior and bedside manner, and that's a very good question because, of course, neurologists are the worst at this. And to the extent that we know anything about it, we learn it from you guys, the psychiatrists. And so to some extent, I may be helpful in that I'm going to take the sort of the neurologist's view of both art and illness behavior. And it's important to remember that for a lot of doctors, the word art is kind of fraught. It's the art of medicine is the unscientific, sketchy part, that you can't put in textbooks. Then we have the slightly more respectable sense of in which the art of medicine is bedside manner. It's what great clinicians do that's not in the books. But then there's also the art of being a patient, which gets fraught again because we worry about artful patients. Now, I included this great picture by Picasso, Science and Charity, where you can see, the neurologist over on the left taking the patient's pulse and not making eye contact, and then you have the caring nurse holding the baby and offering food. And I think that tension will unfortunately shape this talk. I want to make one, I hate talks that start with definitions, but I'm going to do it. I want to just define illness behavior as just globally the responses that we have to the perception of illness. And there may not even be a real illness there, but illness behavior includes all the times when we think there is. Now there's first order responses when we're perceiving our own illness. And that could include like coughing or limping or wincing or hiding our symptoms. And there's a spectrum, I guess I should wave my pointer around, where, like the ideal patient is somewhere in the middle between hysteria, thinking, acting sick when they're maybe not, and stoicism on the other side. I should apologize for using the word hysteria. I actually like it for a lot of reasons, but I'll get back to that. A lot of its negative connotations are really worth thinking about. Then there's the second order response to perceiving illness in others, and that includes helping or fleeing or weeping for them or I thought it said sneezing, sneering, and impassivity, of course. And so we have the art of caregiving, which of course is not just the art of medicine, but what family members have to do and what we have to do when we find someone sick on the street, which can range from over-empathy to indifference. And one of the points of this talk is going to be that these first and second order responses are really linked both in the brain and in our experience and training. And so unless we understand how we respond to others, we don't know how we're going to respond to ourselves. And we should all be listening to this in a very personal way because doctors make really bad patients, which I'll get to my own experiences in a minute. So primary illness behavior has two functions kind of ethologically. One is to protect the organism. You might limp in order to avoid continuing to injure the joint. And the second is to communicate or get help, which is, like screaming. And acting ill has a very long evolutionary history. It's evolved, a lot of it has evolved in as a distress signal. It's also evolved as a trick, and that goes as far back as plovers, who feign having a broken wing in order to lead predators away from their nest, and up to the sort of ostentatious limping that people do, like holding your back. Usually doesn't actually help your back, it's just saying, look where it hurts. And those aren't necessarily malicious tricks. It's a way, what we may do in order to get aid. Now, one of the interesting things about acting sick, as I learned when I used to round with the head vet at MIT when I was doing my PhD there, and he told me that less social animals have less illness behavior because for them, illness behavior is mostly just saying, come eat me. They don't have other members of their troop that are going to help them. And so when we were working with squirrel monkeys, which are pretty solitary, we had to be careful because they looked very stoic. Whereas the rhesus monkeys, they would hold out their hand for the Tums when they would like rub their stomach when they had a stomach ache, and they were very communicative of their distress because they had evolved in groups where they could expect aid. This emphasis on the biology of illness behavior can get pretty wild. A lot of illness behavior, though, has to do with intra-specific combat within species, and a lot of it is about saying, I am no longer a threat. So, in fact, when you watch patients with depression act, a lot of what they're doing is saying, I'm not a threat anymore. And this is something that we see even in lobsters. I don't know if some of you know the great neuroethologist Ed Kravitz, who studied lobster aggression for many years because you got to eat the lobsters at the end of the experiment. So everybody knows who's winning this fight, right? This is not hard to tell. And he actually and other people have shown a lot of the neural circuitry about when in a fight the lobster takes the defeat posture and when they take the winning posture. And it turns out if you give the loser fluoxetine, or I think it's an analog of fluoxetine, that they'll actually restore their aggressive arm waving. Like basically when lobsters fight, all they do is they wave their claws and who's ever taller wins. But the shorter lobster waves his arms longer. The taller one, they're not so bright, says, oh, he must be taller than me. And then the taller lobster adopts the defeat posture. So it's got this very clear neural circuitry, at least at that level. Now, is it glib to compare invertebrates to humans? Of course it is. But when you think about a staff meeting, whoever wins that waves their arms long enough wins. So just saying. And it is true that these defeat behaviors are highly conserved. For instance, the play bow that dogs do when they're signaling that they want to play is actually a non-aggressive behavior, and it's very similar to the kowtow. Here we have the lobster arm waving behavior. So one of the things, of course, with humans is that our illness behavior, our personal primary illness behavior, is not only innate, it's also learned. So we all know that even deaf and blind infants know how to cry and make a face of distress. But as adults, we have to learn when not to do that. And so I'm just going to pause to put on my sweater. It's cold up here. Let's see, I can't dress and think at the same time. So the problem with, I think we all have this ideal that we should act naturally when we're sick and not be manipulative. But if you act naturally, you're actually acting like a baby, and all you're going to get is scorn because you're going to scream when you're pinched, and it's bad. One side thing, a little bit of a tangent, is it's interesting to think about the innate message of tears. And at least a lot of neurologists get this wrong. Maybe you guys are more aware of this, but I just want to go over it. It turns out that in infants, there are no tears. They just scream, and they have a very undifferentiated scream that's just like something is bad. Around about, I forget the age where babies start to have tears. It's certainly before the age of 2. The tears are actually not a pain behavior. They're like an intrapersonal loss behavior. It's missing their parent or having lost a toy or whatever. And Darwin actually studied this. He was obsessed with tears. He seemed to worry about when his babies, he had so many children, when they were going to start crying. And those are all photographs from his work. So with doctors, and I think maybe you guys won't make this mistake, but you may be teaching bedside manner classes to doctors who do make this mistake. We sometimes think that tears are signs of pain, or at least we consciously think that. But at the same time, unconsciously, we know that actually they're a sign of feeling abandoned. And so we get very frustrated when a patient's crying in the ER, and we're like, well, it doesn't really hurt that much. But in fact, they're crying because no one has come and seen them for several hours. So this kind of aspect of the basic versus the learned aspects of all sorts of illness behaviors can get very fraught, even though at some level we unconsciously know it. Now, a second thing that gets really fraught and fascinates me is the way this learned versus innate distinction gets really blurred. The brain doesn't have any clear line between what it considers volitional behavior and reflex. So, on the one hand, we have something that we think of as not intentional with the reflex hammer, and the other, when you choose to kick the ball, is a choice. But so I'm a basal ganglia movement disorder specialist, and it turns out, sort of to my dismay, that's right on the border of this distinction. Almost all of the basal ganglia disorders have this kind of what Mark Hallett calls involuntary quality, where a Tourette's tic, you can kind of suppress it for a while. And so your parents say, well, you can suppress it. Why don't you do that all the time? But it takes a huge amount of work, and as soon as you relax, you do it. Dyskinesias are another example, so that when someone has dyskinesias from a medication, it feels voluntary to them and often doesn't bother them that much. It'll bother the family, and yet it's clearly caused by the med. Now, this border zone between voluntary and involuntary is very upsetting, and in a way all of this talk is about why it's upsetting. But we all know it is because, well, for instance, take my Parkinson's patients. It's very common for, do I have time for this anecdote? Maybe not. But a more broader point is that where we perceive will, where we think an action is voluntary, is right there is the boundary between what we call an illness and what we call a vice, for example, or what we call just weakness of will. So until we understand not only what counts as willful behavior, but also what counts as what influences our perception of what's willful, we can make huge errors about what we think is worthy of medical treatment or not. Now, all of us know that motivations are brain states as well as mental ones. We know this at a very intellectual level, but usually not an emotional level. So I'm just going to flash up these brain pictures, which are some of the studies of where the sense of free will comes from. It involves premotor cortex. Like, for instance, if I stimulate a patient during a surgery in motor cortex, their arm may move and they'll say, oh, well, it just moved on its own. I didn't intend that. But if I stimulate in premotor or supplementary motor cortex, they may say, I just happened to move my arm then. It was a coincidence that you stimulated because they felt the intention. And they're also not just anatomical, but drug effects that can be hugely important. All the time I'm overdosing them with dopamine agonists for their Parkinson's disease, and then they get these weird, very focused, goal-directed behaviors like not just gambling or hypersexuality, but like baking bread all night or making art. And they'll say, this is something I enjoy doing. This is a choice, even though I know if I decrease their agonist, they'll stop doing it. So this brings us to the question of psychosomatic illness, which you guys actually deal with a little bit less than neurologists. Up to 30% of movement disorder clinic patients have a large, quote, psychogenic component to their illness. And one of the things that we constantly do is think of this as acting sick, as something even if it's not consciously, it's subconsciously volitional. But so let's go back to the question of how do we learn to act sick? Of course, part of it is our family. And when you grow up in a neglectful or abusive family, your illness behavior can be very odd. So there's an interesting way in which just having bad illness behavior can get you the diagnosis of psychogenic, or like a histrionic patient. For instance, if you've learned that unless you scream your head off like you're dying, your family will never come to your aid, when you're an adult and you go in for your, for a minor problem, you may greatly exaggerate your symptoms because you've been brought up to exaggerate that way. The doctor senses this and pulls way back, like, oh, this guy's just med-seeking or whatever, at which case you, the patient, then amplify your behavior even more, and you get this vicious cycle where very quickly you have a huge misunderstanding just based on inappropriate behavior. Second place we learn how to act sick, of course, is from the media, and there are interesting studies of, for instance, in England when there was a soap opera that talked about screening for cervical cancer, and just huge amounts of increased screening went up because people had seen it on their favorite soap opera. But again, the bottom line is we have to know how to act sick, whether it's conscious or unconscious, because if you don't get treated like a patient, you get treated like somebody who's drug-seeking or willful. So I want to give an example here of a patient that I took care of, which is William Styron, and also talk about his wife, Rose Styron, because they worked in many interesting ways well together when he was a patient. And Tom Styron mentioned that I had better say that he and I have discussed this and that we're friends, because probably you're thinking, OMG, she doesn't even know that their son is in the audience. So thank you, Tom. So let me back up and say why he became my patient. He was originally sent to me for a problem with his writing hand. He had been in the hospital for depression, and had about like a month into it said, I can't use my hand anymore, I can't write because my hand is paralyzed. And he had this way, like a lot of artists have this problem, they're such good communicators that they come across as exaggerated, and people thought, well, this is psychogenic, or this is his imagination. And he had a long history of seeming very hypochondriacal when he was ill, and but he wasn't using his hand, and they wanted to be good doctors, and so they sent him to me saying, is this, what is this? Well, in fact, he'd had a small stroke, a thalamic stroke, and his hand wasn't working nearly as well. Now his belief that that's why he couldn't write anymore was kind of another matter. So I ended up taking care of him because he also had a lot of Parkinsonian symptoms, and it turned out those were worse on the right side of his body. So some of his hand problem and his feeling that he couldn't control it was actually Parkinson's disease. And finally, just to throw in the mix to these, like the willfulness, the Parkinson's, the stroke, he also had cervical disease, which was giving him ridiculous symptoms in that hand. And but what fascinated me, and I ended up taking care of him for I think about 8 years before he died, he took the role of being sick very, very seriously and in a very conscious way. And he wanted to be a good patient, not in the sense of being a well-behaved patient. That was definitely not his agenda. But he wanted to sort of honor the importance of illness, and he wanted to, it seemed like he thought really hard about it, and he was very explicit about what he was trying to do. And so a lot of what he taught me, which is in a way like you can only learn from an artist, turned out to be applying to a lot of my patients who weren't nearly so articulate. And one of them was just this question of like the exaggerated language that some people use. So I remember the residents would get freaked out because he'd say things like, "My head is shrunk to pinhole size," and they didn't know whether he was delusional or it was a metaphor. And his wife Rose was great about saying, no, that's a metaphor, or no, now he's delusional. Like for instance, when he would no longer put his hat on because he was afraid it would go down over his shoulders because his head had shrunk, then it was delusion. So that fluctuation between metaphor and delusion was something that she was very attuned to. But I've seen this so many times in other patients who will get to the ER. In fact, a Yale graduate student, this was quite a while ago, so you won't know who he is, graduate student in English, who was in the ER saying, I'm suffering like Jesus Christ, and was hospitalized because they thought he was Jesus Christ. They missed the like in the simile. The other thing so I should say one of the reasons that he ended up in my clinic, two reasons. I'll skip them. Sorry about all this internal editing. I remember once reading through his records when I was taking care of him during one of his admissions, and there was a great line from one of the residents who'd admitted him earlier that said, he seems, and it's a very snippy tone, he seems to know more than his doctors, to think he knows more than his doctors about mental illness, which of course was incredibly true. He'd been through quite a lot. He'd written a book about it, and it was interesting to me what had gotten the residents back up so much. Now, so part of the reason that Bill Styron ended up in my clinic was because he was a very difficult patient. So I would just finish my residency. I was a fellow still, and he got bumped down to me because he was difficult. And luckily, we got along great because I didn't have any real belief that I knew a lot about mental illness or Parkinson's disease. And so he was actually, once I wasn't fighting him, it was very easy to work with him. But what made it especially easy was his wife, Rose, who I have such admiration for. I become like her love slave. I follow her around every time I can. She would often, when you're depressed, you outsource your will. You feel powerless. You outsource it to, in his case, his spouse. And so Rose had to do a lot of the things for Bill, like get him motivated to exercise or to go to parties, which normally his will would be able to do for him. But what she was especially good at was standing in for him and dealing with doctors, where he tended to have trouble with that. She was a master, and I learned so much from her about how to get doctors to think that they are making up an idea when it's actually your idea. She was wonderful about that. I'll talk about her more in a minute. But let's back off from this example to talk about what we think is going on in the brains of people who have quote psychogenic symptoms, or I hate this whole contrast between organic and psychogenic and so forth. We know that it's not real, but I'll talk later about why we keep making that distinction. So we have the psychological explanations and unconscious motives, primary gain, secondary gain, even tertiary gain, which we tend to neglect because that's the motives of the doctor, are important. Then there's this interpersonal thing that I've talked about, where symptoms are a way that we communicate our suffering. And then there's expectations, that people behave as if they can't move because they think they can't move. They've been told that they're paralyzed or whatever. And on another level, and these aren't necessarily mutually exclusive, they're just two different sets of language. We can talk about patients with psychogenic symptoms or somatoform symptoms as having maybe defective input. Maybe they're perceiving a problem in their body that they think is wrong, which actually isn't. Then there can be defective processing, like they're over-attending to certain things or they're habituated to something else that they shouldn't be. And then there's defective output, the illness behavior, which as a movement disorder person fascinates me and can be the primary problem. Now, then the problem, though, is that it's very often clear that the somatizers don't have unconscious motives. In SSDI cases, when people are trying to get disability, of course, there have been lots of studies showing how people's behavior changes after they get the payments and so forth. But otherwise, it's not so common for people to have secondary gain. And yet we very, very often attribute secondary gain to patients who come in with a behavior that we think is not organic. I'll talk about this more later, but a lot of it has to do with the fundamental attribution error, which some of you may know means that we see motives in other people's behavior. We use that to explain other people's behavior, and we downplay our own motives. We tend to think, well, I did that because I was forced to by circumstance, but he did that because that's just the kind of person he is. And when patients are sick, of course, if we can't make them better, we have two options. We can think, I'm doing something wrong as the doctor, or you're doing something wrong as the patient. You probably just don't want to get better, and most of us tend to default to that second one. Expectations, of course, come from the brain, and unfortunately where they come, a lot of it is the basal ganglia. Basal ganglia controls our response, like placebo and nocebo responses. Trauma history, as I'm sure you all know, is the highest risk factor for somatoform behavior. I want to stress the basal ganglia role because when the basal ganglia is dysfunctioning, it actually strengthens the placebo effect. You can think of the basal ganglia motor system as blocking our expectations and making sure that we're responding to real events. But when they're not working, placebo becomes very powerful. So with Parkinson's disease, it's actually quite easy for me when I'm adjusting a patient's brain stimulator to, sometimes I'll forget to turn it on, turn on the device, and I'm like tuning away, and they're saying, oh, doc, I feel so much better, and they're walking better, and they feel better, but then I realize I actually never turned it on, and I have to start over. That's magnified in Parkinson's, and especially in dystonia, where people can have their dystonia temporarily go away with hypnosis or when their mood changes, and it causes all these problems because everyone else is like, oh, this is just a psychological problem. The same thing happens in depression, which also screws up your basal ganglia. So we're all very aware of the huge problem in doing depression studies these days, like antidepressant studies, where the placebo effect is so high. Placebo effect wasn't so high 50 years ago because no one believed those drugs worked, and so it's not only is it something where the placebo effect has been changing over time because of our expectations, but also depressed patients are more susceptible to it than somebody might be who's in a study for another type of drug. Just part of the reason I'm showing you this biology is if we can believe that patients, somatizers, have something wrong with their brain, it's a little easier for us to treat them like patients. And so this is more to get you interested in the reality of these symptoms than to remember any of the details. But I wanted to mention this study, for example, with people with, quote, hysterical blindness, where it had happened after a stressor and there was they had normal retinograms and everything. But it turns out that their attentional areas turn out to be, they actually have less activity in their visual area. So why is that not a real condition, And that their attentional areas are actually highly increased activation. And there's a theory that there's simply something in their brain is directing their attention away from visual inputs. But finally, let's go back to the question of will and self-agency. There's a lot of evidence that people with psychosomatic symptoms don't perceive themselves as doing them because of brain activity. So, for instance, Valerie Voon compared people with what was pretty clearly psychogenic tremor to people who were moving their arm voluntarily to people who had what was considered like a essential tremor. And what they saw is that people with psychosomatic tremors had underactivity of a particular brain area. It's the right TPJ, which is an area we know to be important for deciding whether a movement is your own or not, or involuntary. So when that's not active, it doesn't feel like you moving. This is an area that's very important for sense of agency. So people who seem to be they're using their voluntary motor system to have some behavior, but are saying, this isn't me, it may be because this area is simply not active in the right way. So it turns out that somatizers don't usually have abnormal sensation in the primary sense, but there are some cases where that's a role. And I want to give you a great example, which is female redheads. So I'm not sure if you're aware of this, but dentists long had this belief that female redheads were wimps, and they were seen as being more, like they cried harder and so forth. And it turned out that the gene that made them redheaded, the MC1, it's a melanocortin receptor gene, actually made them insensitive to lidocaine. And so they were actually feeling a lot less pain. But surgeons didn't have that stereotype of female redheads because they respond as well or better to morphine, which is what the surgeons were giving them. But more often what's going on is not a primary pain change like that. at least the ones that we know about, more often somatizers have very poor habituation to pain, and that often is the result of, say, their trauma history, where they've learned that more bad stuff is coming and they better not get used to it because they need to escape it. And we've already talked about how poor pain behavior can drive somatization. But when we talk about illness behavior, that's only one end of that spectrum that I described at the beginning. Stoicism also, we have to realize that's a psychogenic state. And so the same brain regions that are helping, like putting us in a situation of, quote, imagining that we're ill, are also very important for imagining illness away. And both of them share a lot of things. There's this abnormal perception of what's going on in your body, like you say, oh, this lump means nothing, or I'm not in pain. And there's abnormal behavior, whether you're seeking too much help or not enough. There's very strong suggestibility. So the athletes that can, keep playing when they're, in pain and so forth, they're very good hypnotic subjects, just as in some cases people with like imaginary or hysterical paralyses are. There's altered cingulate cortex activity in both, and there's bad health outcomes in both because they have these abnormal representations of their body. This example here I love, which is a guy who had a hysterical paralysis of his saluting hand, and he was hypnotized out of it during World War II. When you think about it, though, war bravery is an equally abnormal health behavior. And do I have a slide about that later? Yeah. So I'll talk about that in a minute. So Stoicism and somatization coexist in the same people. So some of you may know the Coconut Grove fire study it was a big disaster in Boston where they studied people immediately after the fire and then later. And the ones that were most calm and to some extent dissociated right after the fire actually were more likely to get PTSD afterwards and have a lot of hypochondriacal symptoms. Another way of looking at it is some of the people we think of as stoic because they never go to the doctor, they're actually avoiding the doctor because they have such a fear of disease. And then finally, patients often misperceive themselves as the other. For instance, a lot of you who've worked in the ER know that someone who says, I have a really high pain threshold after they've just screamed when you pulled the Band-Aid off or whatever, that kind of statement, I have a really high pain threshold, is generally a sign that the person is very much a hypochondriac. And then people who say, I'm just imagining it, this is nothing, they're usually the people that are underreporting and actually have something bad wrong. I think I'm going to skip the anatomy of Stoicism, except to remind you all that in right parietal strokes, people can be completely unaware or uninterested in their injury, and that we sometimes see decreased activity there in people who are simply behaving stoically. And then finally, there are the endorphins. So those of you who, the battlefield analgesia thing, where you've got a gaping flesh wound, but you're still storming the hill to gain control of it. The reason that soldiers don't feel pain in that situation, it's bravery on the one hand, but it's also they're flooded with endorphins. And you can block that kind of battlefield numbness by giving them naloxone. If you look at placebo activity, it's very similar to opiates. So when we're having a placebo effect for pain, often we're having endorphins help us prevent the pain. And this actually can help explain some of the link between these kind of calm, dissociated, numb patients in this Coconut Grove fire and then later being kind of hypersensitive to pain and having PTSD and somatization symptoms because of endorphins. So remember, endorphins are opiates, and we can withdraw from them. So if you're flooded with endorphins during a disaster, you may be quite calm. But then after they eventually fall, you've got opiate withdrawal, just like a heroin addict who isn't getting their heroin, and you may then become hypersensitive to pain because you've downregulated all your opiate receptors during the period when your endorphins were high. And that may explain the weird flip-flops you get in patients with histories of trauma where they've lived through so much and they'll tell you, I'm super brave because I lived through all this stuff. But when you see them, they're overreacting to minor things because their endorphins have gone away and they don't have enough opiate receptors. So there's some theories that's one of the things that mediates the link. But let me now turn to empathy and dispassion. I should mention, I'll talk a little bit more about somatizers. because the reason I get interested in them was because I had this period of being like awful somatizer. At least that was my interpretation of it. I had a lot of illnesses when I was in medical school, not medical school, during my residency. I was like just sort of a weird set of coincidences. I was hit by a truck, and I had acute abdomen from another thing, and I was on 8 different services. And I was like bad. I was a terrible patient. So you know how you see the movie where the doctor learns to be a better doctor from being a patient? I just totally learned that I was a bad patient, and I had better learn to be a better patient, which is one of the reasons that I got interested in what it takes to be a good patient. I started noticing what my great patients were doing that made me a better doctor, and I don't think I ever have managed to do it, but I at least know that it's important. Then once I started realizing how linked the patient behavior and doctor behavior are, I started thinking more about second-order illness behavior. So our behavior, our bedside manner has a biology too. I think most of us know about the mirror neuron system and how empathy is in a certain respect hardwired. Like even in rats, you'll see rats will free other rats before they get their chocolate chip reward. But we should also keep in mind, when I'm talking to psychiatrists, you already know empathy is important. It's different talk than when I talk to surgeons. But for those of us who believe empathy is important, we also have to remember that it's double-edged. Feeling a patient's pain can cause fleeing. It may make you leave the room rather than helping. I remember at one point a literary critic was talking about how can doctors get so callous about their patient's pain, and she said, every time I read Bleak House, it's just more and more painful and sad, and now I can hardly teach it. I just put my head down on the podium and cry. And so that's why a lot of poets don't end up in medicine, because if you're feeling that much empathy, you have to, you need to in some way to be able to tolerate that kind of affect, which is not something that med school tends to teach except indirectly. But what's been interesting to me is many psychiatrists will say, well, we can teach empathic behavior maybe, but we can't teach empathy. And it's pretty clear that's not true, because empathy can change very, very quickly. One great example is Tamar Singer's experiment, which was published in Science a while ago, where they had people they played like an economic game with another person, or they thought it was another person. And that other person either cheated them or played fair. And then they saw what they thought was that other person getting electric shocks. Now, they were actually in a scanner where they saw the video of the patient getting the shocks, the player. And if the other person had played fairly with them and they were shocked, all sorts of empathy activity lighted up in the brain of the subject. But if the other person had cheated them, then actually nothing happened. Or in fact, sometimes even pleasure centers would light up. And this is so very, very quickly, environment can change our empathic behaviors. And clearly, medical school has an even greater effect on empathy. So we have to remember that there are lots of environmental emphases or changes that can affect empathy. The way I learned the caregiver role was not so much from being a patient, but again, the way we learn it is from our family, which none of my family had really been sick, or from art and the media. I don't think I learned all that much from patient-doctor courses, but I was in this remedial program. I was in the weenie track in med school at the MIT MD-PhD program. But I had a weird experience of learning a lot about how to act like a doctor from a TV doctor pilot that I was actually involved with. It was based on the book I wrote, The Midnight Disease, and it was, so I was on the set, so that was the person who played me, and people have asked me, were you did you feel degraded that they got this tall, beautiful blonde person with legs from here to tomorrow playing you? I was like, no, I did not feel degraded. She was actually great. So that's Ever Carradine. She was actually a great, great person to watch. So she was trying to learn my behaviors, walking on my toes. I'm like, don't do that. And I was trying to learn her behaviors, because when she talked to a patient on the set, she looked so much more caring than I did. It was like, so I was imitating her, imitating me, and this life imitating art thing got very dizzy. But it got me interested in doctors acting like doctors. So I went back, and after I was thinking about this, one of my residents had to give a death talk to a patient. And one of the things I should say about Ever was that every time she did a scene, she would do it differently. Like some of the bad actors on the set, they would just do the exact same thing. So I got to see a whole lot of behaviors with her. And it made me a little bit more aware that I could have different behaviors. So my resident's giving this death talk to a family in the ER, in the ICU, and it was really going poorly. It was like, you know, your grandma's going to die, and this is why. And they interpreted us as not taking enough care of her, not caring about her at all. And he was very anxious and a little bit, you know, spectrum-y, and looking at the door. He's a neurologist, right? Looking at the door and drumming his fingers because he really wanted to get out of there. And they were getting angrier and angrier, and I was just watching this whole thing. And finally, I sent him off on some errand. And the family wasn't even so, they calmed down as soon as he left because he was sending so many signals that he just didn't want to be there. And they interpreted that as he hated them. So afterwards, I talked to him and said, you know, oh, I was just at Hollywood and I learned so much about acting like a doctor. And, you know, you could do things like maybe not cross your hands, maybe put your hands open in this sort of like non-aggression gesture. And he's like, wow, you know, that really makes sense. But I can't do that because I always have to do this when I'm anxious. You know, so it's hard to teach bedside manner. People don't believe they can learn, but they can. And after a long time, he did actually learn to do this. But what is it that makes doctors have bedside manner? There's a really interesting link, you know, the Asperger's issue that I mentioned. A lot of bad bedside manner actually looks like acquired autism, even at the brain level. So this was a study of MD training where they showed that after 2 years of medical training, there was a much lower activity in brain empathy areas in functional scans. When patients saw, it was like, I mean, the subjects, the doctors were looking at like a needle stick or a minor procedure that was painful. So there was much less empathy, at least at the brain level, and there was also, as you might expect, a lot more in some self-control areas. So that was actually a pattern that you would see in someone with autism looking at a painful procedure. And it got me thinking about what else is similar. There's the poor eye contact, there's the rapid, monotone, jargon-filled speech. Now, in general, doctors don't have Asperger's. They usually come in with pretty high levels of empathy, and they lose it during med school and especially during residency. But these same things that doctors are doing to protect themselves from their patient's pain, where they don't make eye contact and so forth, it's actually very similar to what people with autism do who find other people's emotion overwhelming. It also raises an interesting and somewhat frivolous point, which is that those areas that are decreased in activity in the cingulate, what if you took doctors and gave them TMS, right? So just increase activity there right before they went to see patients. Like maybe we could cure some bedside manner by using TMS to increase their brain activity there. Just a thought. So as I mentioned, first and second order illness behaviors are very enmeshed. And you know, as we all know, when you as a caregiver are too dispassionate, you can amplify your patient's complaint. But another way that this works is a little bit scarier, which is that empathy can actually make the patient feel their own pain more. There was a German study, it would be German, right, where they showed that saying, you know, oh, this is going to hurt will actually intensify the pain, or making a sad face. And when you think about mass hysteria, there's actually something like that going on too. I was involved a little bit with the response to, you know, the sort of epidemic of Tourette's in Leroy, New York, where it was like I think it was especially you often see this, that cheerleaders are more likely to start this kind of contagious illness behavior, and it got me thinking about why are med students less hysterical than cheerleaders, and is it because we actually don't feel other people's pain as much? So you have cheerleaders who are very attuned to each other's body, they're aware of other people's pain, and they're used to imitating their behavior. And as a med student, I didn't do that because I wasn't as empathic. So that's an aspect of empathy that, you know, that contagious emotion that can really be a problem. And I think some of this is, I think I'll skip that. So for you guys, a lot of you are very good at looking at faces just because you come in with talent. People in neurology don't necessarily, and then we've been trained not to look at expression, but to look for jaundice and stuff. But even in psychiatry, sometimes we can start listening to our patients' words and not look at their faces. In fact, I had my own psychiatrist was German for a while, and she said, "Oh, I'm a better psychiatrist because I don't really understand what you're saying. I just look at your face and I think, oh, she's sad today." So in order, like I actually had, suppressing another anecdote, sorry, for purposes of time. But, so I actually started getting my students, my residents to look at videos of expressions, like Paul Ekman has some great libraries of expressions, but we all know the difference between what's called a Duchenne or emotional smile and a social smile, which we think of as a fake smile, but it's really a smile of agreement. But just as a little quiz, why don't you tell me of which of these is real and which is fake? Or I should say social. So which looked realer?
One on the right?
Yeah. Now, we think, of course, we can do this. So it turns out we can't do this as well as we think. High-status people are less likely to make the distinction because high-status people don't really care. Like if your low-status worker agrees with you, you don't care whether they're actually happy. And men are much worse at it than women. And part of especially with other, like women's smiles, like you don't really care. As long as they're agreeing, it's fine. So we have to keep in mind that we think that we notice the difference when a patient's smiling and saying, yes, I'll take that antidepressant or that blood pressure medicine, that think, is that a real smile, So to get back to motives, when we're diagnosing things, our motive assessment totally shapes what we diagnose. And like I said, we say that the person is sick when their symptoms seem involuntary, but what makes us in our brain judge whether something is voluntary or involuntary turns out to be fairly hardwired. All social animals, to get back to, again, to our monkey troop, all of us, it's very important that we're able to assess motives. And there are certain brain regions like the right TPJ that I mentioned, the medial prefrontal cortex, posterior, I forget STS, superior temporal sulcus, nearly lost it there. These are important for judging others' motives. And even neonates do it pretty much as early as infants can be tested. Paul Bloom and others have done this work. As early as you can test neonates, they seem to make a distinction between willed behaviors and mechanical actions. I put up this, I thought I had the video, but it's just a slide. There's a great video on the web of just these geometric shapes moving around, and the way they move around, you immediately attribute motives to all the shapes. So this brings us to the point that most people default to motival explanations, to explaining other things in terms of will. When they don't know what's going on, they jump to motives. And I think it was John Barrett and then later Dan Dennett made famous the idea of the hyperactive agency detection device, that there's something in our brain that looks for agency even when it's not there. So again, like when a cause is unclear, we want to blame someone. Now, knowledge can counteract this. It may be hardwired, but it can be unlearned. And one of the great stories in psychiatry is people are now starting to believe that depression is not willful behavior, and it's because we know more about the circuitry. We know more that there are drugs that can treat it. Like part of our definition of an illness is if there's a pill that can make it go away, then it's an illness. Now that there's a pill, it becomes something other than weakness of will. The hyperactive agency detection device also explains a lot of the anthropomorphism we do, like when you trip on a rock and you get angry at the rock, or like if there's thunder, it's probably someone is angry angry at you for something you've done, and the whole looking for explanations in terms of the gods. But so I mention this so that we can be aware that we're going to be attributing motives to our patients, whether or not it's useful. And that this is it dies hard. So even those of us who believe that we're materialists, we still, of course, act as if we believe in free will, and we probably should. I mean, there's lots of reasons why if you don't, that's bad. Belief in self-agency, patients who believe that they can change their behavior, they have better outcomes. So I am so not wanting to get into the definition of responsibility. You know, this also has huge legal implications. When is a patient, you know, responsible for what they did, and when were they just sick? But maybe here I'm going to offer a solution anyway, even though I said I wasn't going to. Maybe one way of pragmatically defining it is if rewards and punishments or persuasion alter the behavior, then we can say that it's willed. But if they don't, for instance, somebody who's had a very treatment-resistant drug problem, for example, there's just no point in calling it willful or willed. None of the things that we consider as acting on the will make any difference. So one of the things that was funny when I was involved in that TV show and a couple of other ones is they always had the doctors, they wrote them using medicalese all the time. And I spend all my time telling the residents, oh, please don't talk like that. Don't say bilateral lower extremity to a patient when you mean your legs, you know. But the writers on the scripts would always say, oh, well, no, we have to do that. We want them to sound like doctors, which is, of course, just exactly why the med students are using the jargon too. But there is one good medical use for medicalese, and at least in my practice, this has been helpful. So let's say you have a patient, like one patient I saw who, she'd had a young woman with awful endocarditis who had then developed hyperthyroidism and had a really large course hyperthyroid tremor. Then that was resolved. All of her medical problems were resolved, but she was very anxious about recurrences, and she developed a tremor again and said, I think I've got hyperthyroid, but she didn't. Her thyroid was normal. And so everybody told her, oh, don't worry, you're just anxious, you know, Valium will help. And she's like, no, you don't understand. Like, she was sort of hypervigilant because she had learned, she'd been traumatized by these experiences, that she had to watch out for problems. And I was like maybe the seventh person that saw her. And the only difference I made was to say, you know, instead of stress as your tremors anxiety, was to say that, oh my God, you know, your whole body is on high alert. You have these brain centers that are triggering adrenaline to secrete, which boosts muscles' intrinsic oscillation, so that you've got this chemical tremor. And she's like, oh, wow, you know, that makes sense. And so she said, well, is there any way to treat it? And I said, oh, yeah, Valium will damp that oscillation. And she's like, great. And so she took it. So I was telling her exactly the same thing in a different language, but it made her feel less responsible for what was happening. And in one sense, like, it wasn't her will that was doing it, and that actually liberated her to take the action to change the behavior. So you can see this like totally makes me dizzy. By telling her it was involuntary, she was then able to take a voluntary action to fix it. I went into neurology hoping to understand the mind-body relation, and it just got like so much worse. But at least what we can do is that we can fight our tendency to make the fundamental attribution error, which, as I said, I've covered this, I guess, that we're more likely to blame other people, their actions on motives, than we are on our own. Now let's think a little bit about how mood disorders affect this. I mean, it's sort of more evidence of how fundamental this fundamental error is. So depression is something that makes us feel like we have less agency. It actually tends to make people be more empathic and paranoid. And then in mania, people have a very high sense of self-efficacy. Their empathy often tends to be lower, at least in some early psychoanalytic studies. And they see others as pawns that they can kind of move around. And then you can also see, of course, things like autism, which affect people's sense of self-agency and so forth. And then finally, let's remember our own motives, the importance of tertiary gain. The medical community make billions of dollars off of patients with anxiety-related symptoms and fear of illness. So when we, prescribe 5 more tests to say, just to make sure for medical legal reasons that the person's headaches aren't from a brain tumor, we're also contributing to their anxiety, which we sort of aware of, but we keep doing it anyway. So we're covering our own ass. We're making a lot of money from patients like this, and we have to keep this tertiary gain in perspective when we're thinking about why patients keep coming back to us with worries. So one of the annoying things when doctors talk about psychogenic problems and so forth is that they never talk about solutions. They just talk about how to identify it, like the Hoover maneuver or different tricks that you can do to show that a patient isn't really sick. But what can you do if patients do seem to have symptoms that are not traditionally, neurological? And as some of you know, there are some now behavioral treatments for people with psychogenic symptoms, like, say, PNES, the non-epileptic seizures, that CBT can be pretty helpful for that and for hypochondriasis. There's also some very good evidence now for some physical therapy paradigms. And actually, this is an old slide, and I thought a lot of ways they were working through CBT, just changing patients' expectations. But there's very interesting stuff now being done with, I keep forgetting the name, it's graded motor imagery, which seem to be changing patients' body representations, even using mirror box therapy, like they did with phantom limb pain. Do you know this? I probably shouldn't talk about it because I don't have time to describe it, but patients will consciously be able to put the image of the non-functioning limb on top of the functioning limb on top of the non-functioning limb, so that their body creates a representation of a limb that's working well. And it works not only for phantom limb pain, but also even sometimes for strokes, and also for complex regional pain syndrome, and for different chronic pain syndromes that are thought to have a large psychiatric component. Another thing that I think you psychiatrists, do very unconsciously, because no neurologist believes this, but whenever I tell psychiatrists, they're like, oh yeah, of course we know this. But so I'm bringing it up to say it specifically just because when you're talking to the rest of us, maybe be explicit about this, because this took me a long time to learn, that actually we should mirror anxiety when our patients are anxious. We all learn to mirror sadness, but I think a lot of us are taught, especially surgeons, never show your fear, and it was really helpful to me to have actually a colleague, Alyssa Eli, talking about, I'll think of his name in a minute, who wrote about this explicitly. And she was saying, well, when you're, we'll talk about that in the next slide. So one of the things about anxiety is there's actually a study by Deb Roeder which showed that when you're trying to reassure a patient who's, like, say, they got a scan because they think they have a brain tumor, it's actually more soothing to reassure them in an anxious tone than in a, like, oh, don't worry, you've got, nothing is wrong, don't worry. That's actually not as reassuring as to, like, wrinkle your brow and say, we've got the results back and they're actually okay. And when you put it that way, you realize it sounds like concern, right? You understand how important this is to the person. Whereas if you say, oh, don't worry, there's nothing wrong, it's like saying, I don't even think there's a problem here, you should just forget about it. And patients are naturally going to be suspicious. Again, of course, you're mirroring their fear. You're not saying, I am so worried that we don't know what's going on. You're saying, you must be so worried about this. So I found that life-changing. It's like, especially with anger, like this is what I learned from Alyssa Eli, is just like when you have an angry schizophrenic in the ER, you don't say, this must be really hard for you. You say, you must hate this fucking place. And I didn't have the nerve to try that with angry schizophrenics for a while, so I tried it with my kids. Works really well with kids. Like, you must hate oatmeal, don't you? And bosses and everything. So this is where I learned bedside manner from this. And again, one of the things when you're talking to, like, med students and so forth, it's so much less work for the students and for the surgeons and so forth if they don't have to feign dispassion when they're really upset because the other person's really upset. So if you're trying to, like, wrestle your emotions under control, you have the option of instead saying, you must hate this place. It allows your body language to sort of do what it wants to do anyway, and yet in keeping with expressing their anger and not yours. So here's what I learned. Actually, one of the things I learned this from was watching Rose Styron in the psych ward when she was dealing with the doctors. So she was great at this, and I would see, like, there was a great time when, so Bill was having this big 80th birthday party in, like, a couple weeks, and he was an inpatient, a psych inpatient, with bad depression. And she was saying, well, I think it would be good for him to go to this party. He generally gets cheered up by things like that. So how can we get him there? And I'm like, well, it sounds like a good idea to me, but I don't know if the attending is going to buy this. And so she mentioned this to the attending, and he was like, oh, this is crazy. He's way too sick. And she's like, I know, it's so important to be concerned about that. And she was like raising her voice too. And I thought, oh, I would never do that. I would like try to be calming. But I already knew that she had like the highest social intelligence of anyone I ever met. So I was just watching what was going on. And over the next week or so, she kept mirroring their concern and saying, yes, it's so important we consider this. And and then she would start, once she was resonating at their frequency, she would start to change the frequency a little. And yes, and we want him to get better, and this is going to be a way that we can do it. Totally got them to change their mind. They put him on, they gave him they ended up transferring him to Columbia so that he could go to the party. And one of the great things was that it actually worked. He was so much better at the party. And so I was there partly is that like just to make sure nothing went wrong. But he was standing up, like while he had been an inpatient, he had a lot of psychogenic symptoms. He thought he was going blind. He again thought his hand was paralyzed. And so he would be, I would always stay near him because the hors d'oeuvres came to him first. And so he would say, Alice, do you see that guy across the room? He was in prison and wrote a prison novel. Like I could just barely see this guy, and his vision had improved so much that he could recognize people, and he was standing up straight and waving his cane around after thinking that he couldn't walk. And he started signing autographs with this paralyzed hand. It was just wonderful. And so the next day he was pretty tired and felt miserable, but it was good for a day. So what are some other things that you can do when we're trying to deal with these symptoms that we're not really sure, are they real, are they willful? For instance, whiplash. We all know that whiplash is not a problem in countries where you can't sue for whiplash injury. Like people don't complain of the pain and they don't seem to feel it. And in Australia, they started having like a societal intervention where they posted ads, which basically said in a more clever way, you won't necessarily have neck pain after a car injury. And whiplash complaints actually went down. There's another great kind of societal level treatment that goes on at Cambridge Hospital in Boston. Maggie Allegria, who's a psychologist there, had developed the Right Question Project, which I think is a technique used in other contexts too, where she taught immigrant patients how to act sick American style, basically, where how to frame the complaint, how to get the doctor's attention and so forth. Doctors initially were terrified. They were like, oh my God, now they're just going to complain all the time. When they realized how much more effective it was when the patients knew what to ask for, the doctors started sending their patients to learn how to act sick. There's lots of other things that we could do at a societal level which will never happen, like decreasing trauma exposure, but it would certainly help. And then changing the fee-for-service model, of course, decreases tertiary gain from functional symptoms because we're no longer making money when our patients keep coming back with non-organic complaints. There's also interesting potential pharmacologic treatments. So some of you know the research on D-cycloserine, which is this ancient TB medicine that also turns out to speed extinction learning, and it's been used by people like Carrie Ressler to help unlearning in phobias and so forth. And it looks like it may actually be helpful to extinguish hypochondriacal fears too, when people have this belief that, oh, if X happens, then I'm going to have a bad problem, that they can kind of unlearn that. There's even drugs that block the nocebo effect. So the compound CCK in our body, or CCK blocks our habituation to endorphins, and therefore it blocks the nocebo blockade of endorphins. So you can take it if you've been taking opiates, and it will actually unmask or decrease your habituation to it. And then finally, there's the treatments of antidepressants and anxiolytics. Now, this is really fraught because there are many studies of somatic symptom disorder which show that antidepressants often don't work. There's a couple problems with this. One is there's a selection bias, like the kind of patients that neurologists see, they've already failed antidepressant therapy for their pain by the time we get to them. And then the second problem is, of course, like for neurologists, we give them like, citalopram, and then they come back the next day with a nocebo effect saying, oh, this didn't work because they've already tried a lot of drugs that didn't work, so they expect this won't work either. And then the neurologist gives up and says, oh, we'll do something else, which only adds to the nocebo effect the next time somebody tries an antidepressant. But then there's the third thing, which is that it turns out that people who are depressed and have somatic symptoms, whether it's pain, migraines or stomach pain or whatever, they're much more likely to have bipolar II. than melancholic depression. And so they often don't react well to SSRIs. It turns out that there's 3 times more hypochondriasis in bipolar depression than unipolar. And one paper went so far as to suggest that when people have migraine and depression, that you should consider it bipolar 2 depression until proven otherwise. And in those cases, maybe the pain meds you want to choose are not necessarily an SSRI, but something else. So what a lot of times helps is if you have somebody who's got a lot of somatic complaints and they're very labile, give them an AED, give them lamotrigine or maybe gabapentin or Lyrica, rather than giving them duloxetine or nortriptyline. And then finally, of course, you want to always prophylax and tell them what's going to happen. Is there going to be a nocebo effect? Your body is, you can say, you're used to bad things happening when you take meds, so it's going to be pretty natural that your heart rate's going to go up and you'll feel short of breath for a day or two. That's just your danger center going on overdrive, and that's going to calm down if you can just get through that. So I think that I had better stop. I hate conclusion slides because they're just so full of truisms. But here's my truism slide. There's lots of hardwire aspects of acting sick and playing doctor. We all know that learned aspects can be learned better, but like, how do we learn it? That's where this is a little bit less truisms, that we have to remember not just to listen to what they're saying, watch their faces, and then we don't want to act autistic, like we should make eye contact when it's appropriate, but we also want to dial down our motive perception. We don't want to do the opposite of autism, where we're looking for motives everywhere. And as Rose taught me, we should dimly mirror negative emotions rather than just returning them. And yeah, so there's a whole other part of this talk, which is the relationship with illness and art, but instead maybe I should pause and ask for questions.